We will be discussing partial ACL tears and how to reconstruct the ACL in these cases with preservation of the stump. In this MRI, we see a completely torn ACL from its femoral attachment with complete disruption of the ACL. This is a torn ACL. But in cases like this one, we can see some continuity of the fibers reaching to the femur with a thin and fuzzy ACL. This is what we call partial ACL tear. Sometimes in the MRI reports they write ACL sprain, which is a relatively inaccurate term. To have a completely intact ACL, we should see intact fibers from the tibia reaching to the femur in at least 2 consecutive cuts and no indirect signs. But in partial ACL injuries, there is usually a complaint which could be occasional giving way, there could be effusion with exertion, there is pain, and in examination there is a difference in stability between the injured and the uninjured side. Although we don't have a +3 drawer and usually the pivot shift is negative. So we can see an ACL fibers, but they are thinned and we can see them in only one cut. So if you see the examination of the left knee compared to the right knee, there is a clear difference. It's not a striking +3 anterior drawer, but there is a definite difference. So if this patient is complaining from occasional giving way of this left knee, this complaint should be considered, should be respected, and if we neglect it, he can present even later with a meniscal tear because it's an unstable knee. So if you see fuzzy fibers of the ACL, this is a sign of ACL injury, although we can see that these fibers extend from the tibia to the femur. And of course, if we see the characteristic bony contusions on the posterior aspect of the lateral tibial plateau and in the mid-femoral lateral femoral condyle, this is a classic indirect sign for an ACL injury. The ACL, as we know, has different collagen orientations and has wide insertion sites on the tibia and the femur. And therefore, if we want to reconstruct an ACL, we want to try to be as close as possible to the anatomy. And if we look at this anatomy, we look at the insertion on the femur and the tibia, we can see that the direct insertion on the femur, which is in the depression between the lateral intercondylar ridge and the articular margin, it's a wide area. It's almost 18 millimeters in length and 8 millimeters in width. It's rectangular. And of course, you cannot fill this area 18 millimeter in length by an 8 or 9 millimeter rounded graft. And therefore, it's wise enough to leave whatever of the ACL that is still attached in this area in cases of partial injuries, instead of removing the whole attachment to have a wide view and then do your reconstruction. So the femoral ACL attachment, we have this direct rectangular large area of attachment, and then we have what we call the indirect fibers, which extend even more posteriorly to reach to the articular surface in a fan-shaped manner. Moving to the tibial attachment, this is even more complex. It's more or less like a C-shaped attachment, which is 11 millimeters in the coronal plane and 17 millimeters in the sagittal plane. Again, you cannot reconstruct an ACL with a rounded graft to fill this whole tibial attachment. So it's wise enough to leave whatever tissues of the native ACL that are still in this place. So this is a right knee. This patient had a mid-substance ACL tear. And look, this is the femoral attachment of the ACL. We are looking from the anterolateral portal. These are the direct fibers. These are behind or below the intercondylar ridge. It's a large rectangular area. And if you go behind it, you can see the fan-shaped extension of the indirect fibers. And this is the tibial attachment of the ACL. It's a large collagen fill area. This is the posterior edge of the anterior horn of the lateral meniscus. This whole area is a large tibial footprint that you never can fill with a rounded graft, the ACL, and it extends anteriorly, so far anteriorly that it goes even under the intermeniscal ligament to reach up till the anterior limit of the tibial plateau. So this whole area is the collagen fill of the tibial attachment of the ACL. You cannot reconstruct this with a graft, so it's wise enough to leave whatever you can leave from this while reconstructing a partial injury. What we used to do, this is again a right knee looking from the anterolateral portal, is to remove the whole femoral attachment to have a wide view of the where we would like to put our graft, and then say this is the over the top position, this is the lateral intercondylar ridge, and then we will be below the ridge midway between up and down to be on the, for example, the 10 o'clock position for the right knee and do our graft. This is what we used to do, but we are removing too much of the ACL if there was still residual connections to the femur, and we are losing the collagen fill on the femoral side. So let's go to this case. Again, it's a right knee. It's a 25 years male complaining of occasional giving way for the past 3 months post a twisting injury. He has a positive anterior drawer enlargement test. We can see some remnants of the ACL between the tibia and the femur. It's a fuzzy ACL. And looking in the coronal images, we can see that there is an injury at the femoral attachment. So looking from the anterolateral portal, you can see that the ACL, it looks okay. But that's not, we're looking at the tibia and the mid-substance. But if we go turn our scope to see the femoral attachment, you will see that the ACL on the femoral side is attached far posterior on the femur. So it's almost reaching to the articular edge, the place where the indirect fibers are usually attached. And this is where we're pointing. This is the area where the most of the direct fibers should be attached. Most of them are no longer attached. So this is a partial ACL injury. Some of the fibers are still attached far posterior on the lateral femoral condyle, but most of the fibers are torn. So we don't need to remove these fibers that are still attached to the posterior edge of the lateral femoral condyle. Leave them in place and then do your reconstruction, being below the intercondylar ridge, of course, perpendicular with the PCL, and this is where we want to put our graft, leaving the native injured ACL as it is. It serves as a good source of proprioceptors, and it helps with the collagen fill on the femoral and the tibial sides, and it even helps with the vascularization of our graft. So this is the native ACL. It's left in place. We don't remove any part of it. We just leave it in place, and we go just anterior to it on the femoral side and do our femoral tunnel. Usually the graft is, since we're leaving this, the graft is between 7 and 8 millimeters. 8 millimeters is fine. You can do a triple semi-T. And this is on the tibial side. This is the posterior edge of the anterior horn of the lateral meniscus. We use it as a landmark. And then we move to the intercondylar area. And we go in the middle of the ACL, native ACL. And this is where we would want to pass our graft. So we start with the tibial tunnel after having made the femoral tunnel. We don't remove any part of the native ACL, so this is the guide wire. And then we do a little bit of shaving, going with the shaver through the tibial tunnel, just to clear the way for the graft as we pass it. Otherwise, it will get entangled within the native ACL. So just clearing the way. A little bit of clearing the way for the graft, but without injuring the native ACL. We want these fibers, we want the proprioceptors, and we want the collagen fill. And then going through the tibial tunnel, because we have made an anatomic transportal drilling of the femur, we go and we shuttle our loop for the femoral tunnel to go down through the tibial tunnel. And now we're using a suspensory fixation. We are pulling our graft now. We're actually delivering the graft through the native ACL. So this is the graft as it passes through the native ACL. One would say, but I have not seen the femur as clearly as I want. Once you've seen the lateral intercondylar ridge, it's fine, because all you need to do is to go below it. You don't need to remove the fibers that are even lower and expose the posterior articular surface and see the popliteal fossa and your over the top position. You don't need to do this. So this is the graft and this is the native ACL, as we can see. So this is the graft surrounded by the native ACL, giving a proper collagen fill. We can see as we extend the knee that we have no impingement. So this is a stump preservation ACL reconstruction. You can see the graft going within the native ACL. This is another right knee with a partial ACL injury, for which we are going to do a stump preservation ACL reconstruction. We've done the femoral tunnel below the lateral intercondylar ridge, transportal drilling. You can see the femoral tunnel. It's just in front of the remnant, the femoral remnant of the native ACL. We are now trying to see the clock. This is the 12 o'clock position. So we are in the 10 o'clock position for the right knee, which is excellent for the femoral tunnel. So it's a horizontal tunnel. It's in the right place. There is no blowout and it's completely below the lateral intercondylar ridge. And we are leaving this ACL remnant. We don't need to remove it. See, this is the ACL remnant in the partial injury. We're leaving the tibial attachment, the mid-substance, and the posterior fibers attached to the femur. They are all left intact. So it looks like an ACL through which we are going to deliver our ACL graft. So leaving the native ACL, whole of it. We don't remove any part of the native ACL. And then you're delivering the graft through it. One would argue, will there be an impingement? No, there will not be an impingement, because the native ACL is far posterior. It's not anterior on the femoral side, so it will not impinge. So you can see we have delivered the graft through the native ACL. We are benefiting from the proprioceptors on the surface of the native ACL. We have an excellent collagen fill, which can never be made only by the rounded 9mm or 8mm. This is an 8mm graft actually. You can never have this whole collagen fill with this graft size. Now this is the native ACL we are palpating on, extending far posterior. This is the graft, and this is the mid-substance and the tibial attachment of the native ACL, and this is our graft. And this is the native ACL. So it's delivering the graft through the native ACL without removing any part of it, especially in cases where we have a partial ACL injury and some of the fibers are still there on the femoral attachment. Again, we're extending the knee fully to make sure that there is no impingement, and there is no impingement, as we discussed earlier. So the take-home message is always respect the patient's complaint. If there's giving way, even with a partial injury, it's a significant complaint, because unstable knees will lead to meniscal tears. And therefore, look carefully at the ACL femoral attachment during your scope. Don't just look at the tibia and the mid-substance and palpate for tension. You have to see where the ACL is attached on the femur. Is it in the right footprint, or is it going lower down and posterior? If we preserve the ACL stump during reconstruction, this leads to better collagen fill, of course, on the femoral, tibial, and mid-substance areas, better proprioception because the proprioceptors on the surface of the native ACL are left, and even it aids with the vascularity of the graft and hence faster ligamentization. This case had an ACL reconstruction, and the MRI was done in less than 3 months post-reconstruction, and we can see the excellent ligamentization after less than 3 months. Thank you.